Our moderator for this panel will be Josh Rizzo. Josh graduated from the United States Military Academy at West Point in 2002, where he lettered on the varsity baseball team 4 years, served as team captain, and was the recipient of the Doubleday Society Award for Leadership. Josh continues serving in the military as an officer in the United States Army from 2002 to 2007. He achieved rank of captain, deploying to Iraq as a company commander in 2005 and 6, where he was awarded the Bronze Star Medal. Josh co-founded PTSD United in 2013 as a need to help large populations suffering from PTSD on a daily basis. He currently serves as executive director and a member of the board. Josh will also be receiving the 2015 Invisible Heroes Award at this evening's gala, so we look forward to giving him that, and we hope you plan on attending. It will be an incredible evening, to be sure. But Josh, if you would lead us through this final panel. Thank you very much. Josh Rizzo, ladies and gentlemen. Thank you, sir. Yep.
Thank you. Thank you for the introduction. That was really nice. I'm really grateful to be here today, and for a number of reasons. One, Jim just ended with saying there's hope, and God, I'm losing it already, right? So Jim ended with saying there's hope, and I'm so filled with hope in this room. I sit here and I'm struggling with my post-traumatic stress, here today, every day, and being part of a social community at Huddle, which I'll speak more about later. There were days that were really dark for me, and I didn't know that you people were here. I didn't know there were a bunch of people at work on my behalf. I mean, it's amazing to see all these wonderful people here. We're sharing stories and ideas. We're making each other laugh. We're trying to keep some people awake. We're having a great time, and we're sharing. And for me to just hear the work that's being done and get these ideas from you guys and be able to go back and get on Huddle tonight and share some of the things we've learned, with some of those folks that don't know, the work that's being done and the innovation that's happening and the wonderful hearts and the hope that's out there. This is just, I'm humbled and I'm grateful to be here, and I'm really, really excited to be sharing a stage with you guys. Thank you. So I've got a few questions. I'm going to ask one, and then I'll go to the crowd for the next one. This is actually for Jim. If you would, EMDR is something that for the community with post-traumatic stress, especially the veteran community, it's kind of one of those things. I don't know what the issue is, but it's not really publicized, and it's not readily available, at least in my personal experience and with the community that I serve. Could you tell us a little bit more about maybe a case study in a breakthrough that you've had, with somebody, with a patient, or withholding their name, obviously?
Well, yeah. I mean, there have been many combat veterans that I've worked with who came in, and usually it's not a situation where there's one particular traumatic event. It's a whole series of events that a person has had. I've had people come in from the Afghanistan and Iraq wars, but also from Vietnam, from the Gulf War of about 23 years ago, and even World War II, Korean War. I think that what I've seen with people is, I think that this is what gives me a lot of sense of meaningfulness about doing this work, is that when you're carrying around something that is troubling to you, and it's in the background for years and years and years, and you have loving family and friends that want to help, but they don't, it's hard to explain after a while why it just continues and continues. And for a person like that to get to the point of really realizing it's gone now. I can think about those things on purpose. The images that were flashing in my head before that I'll never forget. One guy getting out of a landing craft in the South Pacific in 1943, and his three close friends got out before him, and each one was shot dead in front of him, and now it's his turn to get out. Well, he survived, but that was an image that kept coming into his mind way up until when he came into therapy in 2003. And to help a person really realize that stuff, they can think about it now, it's just a memory. And people will say, it's not like being in the movie anymore. It's like looking at a photograph or something now. And that's really gratifying to me. I think what really I get from this whole gathering here is something that I think is really crucial, which is there are resources available, us and many other people that do the kind of work we do, and there's a great need out there. And how do you connect up the two? I think it's really an issue. That's the main issue, I think, in getting help to the people that need it. That's true for disaster situations in Turkey. We had a hell of a time getting people that were traumatized to be willing to come into the little clinic we had. They didn't want, they're going to handle it. I'm tough. The men were just, staring at the walls of their tent for months on end, and the women would come for their children. And so that's how we finally got them to come in and get some therapy for themselves. But I think that's always an issue. And as far as the access for the military veterans, I think it's partly a political issue there too. At every installation of the VA, also within active duty facilities, the person who decides what therapy methods can be used is the commander, who's often a psychiatrist. And psychiatrists in general are more tuned into drugs and not so tuned into doing therapy. So they don't recognize, the importance of having the very best proven therapies. And so we need to do this. We need to get the people together, with the helpers together with those in need.
Put one more here before I go to the audience. Rick, you mentioned, with all the misdiagnoses, what can we as patients do to ensure that we're receiving better health care and correct diagnoses at our level?
The report that I referred to talked quite a bit about patient involvement in communication with the doctor, collaborating with the doctor, making sure that it's more of a partnership. And the report is talking to patients, but it's also talking to the doctors in terms of getting more information from your patients. And it's not settling for the first diagnosis that is presented, getting a second, getting a third, getting more information. I emphasize the data analytics part of what we do. We're starting to see the rise of healthcare IT more and more. We're starting to get more measurements and better measurements. So you need to get this. It's very easy, as you think about from our cultural standpoint, as we grew up, the pediatrician, the doctor, was this authority figure that we all looked up to. And we went in, and what the doctor said was what the doctor said, and that's what went. Well, doctors, as you could see, make errors. They make diagnostic errors. And it's not just a subjective opinion that we should be getting anymore, because there's way too much data out there to inform the diagnoses. But the doctors also need the education and training to understand what data is useful for them. They still ultimately have to make the diagnosis, but there's more and more things available today. IBM Watson. You've all heard probably about IBM Watson. It's basically an artificial intelligence database that is mining the medical literature. Medical students have been putting data into IBM Watson now for the past couple of years. We're going to start seeing clinical decision support systems coming out of Watson. In fact, we're working on one today called Ceremetrics at Cerescan. In probably sometime next year, we will have this out as a clinical decision support system for any doctor that has sent a patient in for Q-spec imaging. So it's getting data. It's not just taking someone's subjective opinion, but digging deeper. And the patient has to be responsible for their own health care as well.
would you say overall being more proactive and then
Yes.
asking for data to back up the
Yes.
decisions and
Yeah.
diagnoses?
Yeah. Asking questions and telling the doctor what's going on as best you can. It's hard sometimes for patients to really to describe their symptoms, but doctors need to be able to also have good communication skills in pulling that out.
Awesome. Thank you. And before we go to the audience here, Karen, can you talk a little bit more about, you showed the physical gains and the progress, and then you spoke a little bit about the mood of the patients. I saw some group pictures up there, which was really encouraging to me. Just with our background, and everything's very highly socially engaged, and just asking if you could maybe speak a little bit more about the physical gains and how they correlate to the mood and vice versa, and the overall wellness of those clients of yours.
Okay, I'll see if I can address that. So yeah, the physical part really does translate into a more motivated person. We've seen that they have more hope, they get out there and do more things. And Tina was here, and just recently she's decided that she's now has enough confidence. So we've built her confidence up to the point where now she's going out with friends. She's going out with her friends, doing fun things. She came today all by herself. So the motivation piece just picks up, and then they also start taking more responsibility for their own health. So they'll come to us and say, this is what's going on, what should I do about it? And then we send them out to the doctors or wherever they need to be. So it's helping them socially. They're getting out there and actually being social with their friends, meeting new people. They're not afraid to step out and say, look at me. There's nothing wrong with me. I just may not be able to talk right, or I can't move quite right, but I have the confidence to say that I'm a real person, I'm a whole person. Don't be afraid of me.
Is she the one that has, Tina, is she the one that has the Corvette?
Yeah.
Okay, I need to talk to her.
All right, we'd like to open it up for some questions. I think we have one over here.
Yes. Why you said that hyperbaric looked promising? Why is it just promising? Because it's been around for quite a while.
It is still somewhat controversial. It has been around for some time. It was originally used for divers that got the bends, of course,
Yeah.
as we know. But there's been a lot of success. There's been good research that shows that it does seem to be successful for TBI, but there has been other research that has shown that it's not. So that when I say it's promising, I do think it is, but I think that the door is still a little bit open on that from a research standpoint.
Okay. Thank
A couple of points or questions. For the PTSD presentation, are you familiar with another technique called brain spotting?
Oh, yes, yes.
And how have you found that to compare with EMDR? And also the MDMA studies. Are you familiar with those?
No, I'm not familiar with those.
Yeah, so they're doing MDMA studies. Which
Oh,
is
yeah,
ecstasy
MDMA, yeah, okay, I'm sorry.
For PTSD, and they're
Right.
finding that that's extremely effective.
Right, I'm not as familiar with those results. I am familiar with brain spotting. David Grand is a therapist in New York and has developed a method which he differentiates from EMDR, although it really has quite a bit in common with EMDR. And he tells about how that's quite effective. What he does is he asks people to locate a particular spot in their experience that represents a certain state of mind or ego state. And then he helps the client alternate between those different states of mind in a way that is useful and therapeutic in processing traumatic experience. His variation on it, I think, is something that he's talked about with lots of case studies, but he hasn't, the experimental, the research support for that is not yet forthcoming.
Yeah, the MDMA seems to work very effectively to counter dissociation and bring
Yes,
the person into their body and allow them to
That's
go
right.
through the emotion related to the trauma. And then in terms of the head injury presentation, are you familiar with, there's a type of vibrating platform called ZAZZ, Z-A-Z-Z, which I think was developed in Russia for astronauts, and it's supposed to vibrate you in different directions.
That's new to me.
So, and are you interested in other technologies? Do you have a
Absolutely. Yeah.
foundation?
Yes.
And are you familiar with the National Intrepid Center
Sure.
of Excellence?
Sure.
'Cause they're also interested in.
Oh, yeah, sure. There's a lot going on, I think, in brain health today. There's emerging research, and we're interested in being able to do that, in particular, looking at the outcome measures. You know, what really does work? How does it work? Does it improve symptoms or reduce symptoms? Does it improve cognitive functioning? Does it improve blood flow or metabolic rate? PET-CT measures metabolic rate. So there's things that we need to be able to put a stake in the ground and say, this works or this doesn't work. And I think one of the things I'm most excited about is actually some of the combinations. So if you think about the polychromatic light therapy that I was talking about, and you can stimulate blood flow in the brain, and you marry that with, let's say, neurofeedback, or integrated listening systems that we heard earlier today, and capitalize on neuroplasticity. Is there a synergistic effect between some of these modalities? They tend to be studied in isolation, but we need to get into studying these in terms of the interactive effect
Do
between.
you have a foundation that's willing to support these studies? Is that?
We are always looking for a foundation that can help support the studies. Yeah,
And do you do the light therapy yourselves?
I do. Me personally, I do.
No, I mean, is it available? Can one come
Oh,
to
is it
your
available?
clinic and
We are working with the manufacturer of that device, and there will be basically a new generation device that will be coming out in first quarter, and we will have that available. It will be called a Ceralight.
Okay, thank you.
Thank you.
I had a question for Jim regarding EMDR. And would that be available as a therapy to pedophiles in the prison system? Or is that one of those things that are kind of locked down away from you? And then my second softer question would be, on one of your slides, step 7 of EMDR, listed the word closure. And I hear that bandied about, and I kind of was like, maybe I know what that means, until I heard someone boldly say, what the hell does that mean, closure? You know?
Okay. Well, as far as whether that is available for people in the prison systems, I really don't know if that's available here in Colorado. I know that there has been EMDR used with people in Colorado State Hospital and also in the unit of the penitentiary in Canyon City, where people go if they've had some type of mental disorder, and it's been effective with some people. I don't know the data exactly how that's turned out. The work with pedophiles was done, I think, in Pennsylvania with people that were incarcerated. So it's one of these things where it's been shown to be effective. And then we have this process that is kind of very slow-moving sometimes of acceptance into the procedures. You have people in a position to say yes or no that therapy can be allowed in that setting. Sometimes it's a process of them seeing for themselves that it could be useful. And so that's kind of the step we're at now in terms of that particular procedure. As far as the word closure, when a person is going through therapy for a traumatic event, oftentimes they'll have a few moments of actually reliving the worst part of it. And that's something that is often feared before the therapy. It's enough to keep people from going into therapy sometimes, but it doesn't last that long. And they're saying they're kind of having that experience for the last time, oftentimes. If a therapy session is incomplete, there's a way of measuring that. A person might come in and be asked, okay, when you think of that old trauma, how disturbing is it to you on a scale from 0 to 10? They might say, 8, 9, maybe 10, 10 plus. They give a number like that. They might go through an hour of therapy, and at the end of the therapy, they might say, that session, they might say, it's a 4 now, which isn't all wonderful yet, but it's a lot better than how they were in the beginning. When that happens, it's important for the therapist to know ways of helping that person put a nice finish to the session so they don't have to keep on having that feeling that with those flashing feelings as they leave the session and go out into the world again. So the closure aspect of EMDR is a set of procedures that can be used by therapists, and this is part of the EMDR initial training to help the therapist learn how to really help a client leave a session in a good place. So that's basically what that word means. Yeah.
Thanks, Jim. How are we doing on time, Wayne? All right.
So, Karen, question for you. You listen to what Rick and Jim have to say. How do you see the implications of the research, what they're doing, coming through into the practical application every day? So you listen to them. What hope does it give to you? How do you see what they're doing applying every day in your place?
Well, I can see the physical ramifications of what's going on, but I don't know what's happening other than that. So I would like to, like you were talking about, Rick, about how we put things together. I would love to work with ILS to see what their movement therapy would work with our guys. Love to see what's happening in the brain. I would love to see like coordination with the stroke society or the stroke population. See how that's going, because stroke is traumatic brain injury. So it's kind of the same field. We work with the same type of people. It'd be great to see how what I'm doing in the hands-on stuff, what happens 2 weeks later. Are we getting results? Are we seeing changes, or are we just going through the motions?
Karen, if I may jump in, something I was chatting with our presenters about earlier before we came out, the community, the social community that we run at Huddle, it's for post-traumatic stress survivors, and a nice chunk of those post-traumatic stress survivors are cancer and stroke survivors. So we get to see the back end of that a little bit, and I was so interested in what you do, on the physical side and how it affects mood, because all I get to see is that other side. So it's so cool that you asked that question, and I'm sitting here because a lot of our stroke survivors, it seems that when they took an approach to their physical therapy following stroke, they had a bit more of a rigor and a bit more of almost a dogmatic approach to the mental health, and treated it almost as brain health, and as one thing, as a body, kind of what everybody was alluding to today. So we get to see that and how it correlates, I guess. That's something, maybe that's a takeaway from this, maybe getting some folks involved in your program and our program, putting them together and seeing, how that all affects on the backside of the PTSD or the PTS and having a stroke. So it's very interesting to me as well.
I would think that PTSD is very strongly implicated in people that have had strokes, because it's a loss, a huge loss, and that's traumatic. And my guess is sometimes when you're talking to people and they come to realize at a certain moment that they can't do something that they used to be able to do, oftentimes you see a lot of emotion with that, I would guess. And that would be the PTSD part. And yes, there is a lot that can be done to help people with that, and not only reduce maybe the grief they've had about their loss, but also to enhance what you're already doing through your example and your enthusiasm to help them motivate to have some new normal that is it's not the end of their life. There's a loss. We all have losses in our life. We all have people that we've lost that are loved ones. We've grieved about it, and then time passes, and grief can be a healing emotion that way. And so I would think that it would be quite important with the people you're working with.
Thank you. Firstly, it's an incredible array of interventions, and one of the things that we've been seeing in the brain is small things, nudges, can make huge differences if it's the right thing in the right person. So all of your emphasis on personalization is what I think is the most hopeful thing. But an issue, and Wayne, I'd hope the Invisible Disabilities is such a unique association. So my question is, one of the biggest advances we saw was by standardizing a little bit of what's going on. So, for example, if people are going to do SPECT studies with PTSD, if they could be encouraged to use the same SPECT system and the same analysis, not everybody, but just what we call the coalition of the willing. And it doesn't matter whether it's SPECT or whether it's cognition or whatever it is. So my question is, do you do that? And I just would like to leave you with that thought if you don't.
I mentioned a moment ago, basically an artificial intelligence system or a clinical decision support system that we are working on called Ceremetrics. And Ceremetrics will be a way to standardize SPECT imaging from the patient protocols, from the moment the patient walks in the door to the time you put them on the camera and acquire the images, the way in which you process that data. All of that we are standardizing, and part of Ceremetrics will be a licensing model where we will go out to hospitals that do SPECT imaging, teach them how to do that, and then have that standardized process there. What that does is it brings data in, and within Ceremetrics, what we are creating, in a sense, conceptually, is normal populations of abnormal disorders. So what does a normal curve look like for ADHD? What does a normal curve look like for Alzheimer's patients? What does a normal curve like within brain disorders? So once you have that data, now new patients coming in not only informs the database and it's continually learning, but it goes back to the doctor in terms of what the most likely diagnosis is. And it's not just one thing, it's usually a comorbid situation. We don't tend to see simple cases at Cerescan. We tend to see complex cases, people that have comorbid situations. But that's the direction that we are going. It's a great question, and we would love to see this standardized in SPECT imaging, PET imaging as well across the country.
And look, I'd like to address that also, that with regard to EMDR, EMDR is what's called a manualized procedure. There's a certain procedure that is followed in targeting a particular, well-remembered traumatic memory that is disturbing to a person, and if that procedure is followed, the result is fairly well predictable and very reliable. And sessions, an EMDR session, and this is done in research routinely now, are videotaped usually in a research study, and they then are rated for how faithful they are to the basic protocol. So it is manualized. However, people come in all different ways, of course, into therapy, and so these things need to be modified in real life. But usually for research, it's standardized.
So yeah, just to make the point, the beauty of that is with standardization of anything is then you can then see what works,
Yes.
who it works in,
Yep.
who it doesn't work in, and you remove a lot of the skepticism, and you really are able to focus on even repetition of your therapy is fantastic, by the way, and your patients is like mind blowing. But even that, for other therapists to be given a prototypical of how to do it. And last but not least, there's a man called Stephen Koslow, who is the inaugural head of the Human Brain Project in Washington. And I would urge this organization to get in contact with him because he set up databases across the United States and he really, I think, would be very helpful in encouraging the kind of some of the methodological things where you could see the personalization more effectively. I mean, but it's just fantastic.
Great idea.
One last question before we close it out.
My question is that we all know that the American Medical Association has an enormous amount of power, and we know that funding is getting more and more difficult from NIH, and we all are experiencing this. We're also in the process of sort of a revolution in healthcare. So what can we do out here as citizens to promote this kind of research and this kind of treatment so that it becomes standard of care, so that insurance will cover the kinds of treatments that you all do? Because we know that the reason that people like you don't know about it is because it isn't mainstream. So what can we do to help it become mainstream?
Good question.
That's a really good question.
This is cutting edge. You could say this, and I think it's just been true throughout recent history that new innovations in any medical procedure take a long time to be accepted. Lithium carbonate is used as a treatment for bipolar disorder. that was discovered in the 40s. It wasn't adopted into standard practice until the 1960s when a drug company obtained the patent on lithium carbonate. And then it was publicized, and suddenly you saw a huge burst of diagnoses of bipolar disorder, or manic depression it was called back then. So in other words, there's other aspects besides something being effective that contribute to it these effective methods not being used. You say they're political, that makes it sound kind of conspiratorial. I think it's just how slowly it takes sometimes for things to be incorporated. And word of mouth is important, publicity is important, telling, if you know someone who's in a position of influence and you know about effective treatment, tell them.
What about writing to legislators?
I think that is important. I think that we underestimate the impact that it has when you actually send an email. Don't send snail mail. Send an email to your congresspeople. But I will tell you that we're really not interested in NIH funding. We're not going after that. It is too long of a process. It is too great of a bureaucracy. We would rather see smaller proof of concept studies that have not such great funding requirements to be able to begin to show what seems to work and what doesn't work, and hopefully stimulate other researchers and even follow-on projects ourselves to go to the next level with those dollars. But some of the government dollars, it's just, I don't want to get, that's a morass. I just don't want to get embroiled in that.
Thank you. Well, Jim, Rick, Karen, it's been an honor to share a stage with you. Thank you so much. I appreciate the time.
Josh, thank you as well, sir.